Hi, everyone. I am going to record from our classroom today, but I'm going to continue with GU or genitourinary surgery. So I will go ahead and share my screen so that you can follow along with me with my slideshow. You will see where I stopped last time was your kidney anatomy. I don't know if you could tell, but I was looking at my dog in the corner of the room. She was about to start barking. So I went ahead and stopped at our kidney anatomy. I was going to finish that one off, but that's okay. I will start from there. So I will go ahead and hit present here. And now you can follow along. So I'm going to start on page 818. It's an open simple nephrectomy, but we talked a little bit about the differences with nephrectomies. You know, that could be radical, could be simple, could be total or subtotal. So make sure that you know the difference between each of those based off of the name and what position they're going to be in to do the case. So on page 818, you'll see instead of really getting into the open simple nephrectomy, they start going over the anatomy. So I know, at least for me in school, that was a difficult part of anatomy to understand. So even though I won't review over the details, I will add this picture in here for you to help you do your own review. So really read through page 818, know it well, especially the center section. So it's all in bullet points, but that center section really gets into what crosses over what in your body. So reading it is kind of difficult. You have to have a visual to go with it. So a reminder for you, if you need any of the pictures here in our classroom, I have this flip book for you so you can look at that anatomy if it helps you. I have the male anatomy up for urinary tract and for some of our GU surgery, but I have one just for kidneys. You can go back and look at your review from when you learned the urinary system. You can go back through all of that. And of course, you still have your medical terminology book, so you can use that to study your anatomy. But if you have any questions, please ask me. So your center section, so let me tell you what to focus on. It talks about the medial border of the right kidney and its relationship with the duodenum. It also talks about the pancreas. Find the bullet point that talks about the pancreas. The pancreas lies across the hilum of the kidney, but specifically the left kidney. So all of these things are difficult to understand when you're just reading it, but if you're looking at a picture of abdominal organs and the anatomy, it will make more sense to you. So as you're reading through this page, 818, I urge you to have your books open, look at the abdominal cavity and the different organs and how they're going to lie in relation to the kidneys. That's what it's wanting you to focus on. So example, the pancreas lies across the hilum of the left kidney. It's very specific, something that you need to be able to visualize when you're reading black and white words. Another one, the stomach and the spleen contacts the superior portion of that left kidney. So it's focusing on the left kidney. Now, if you have a question like that, you should be able to critically think your way through it, right? You don't have to memorize these words in the book. You just have to know your anatomy. So if you got a question about what portion is touching the left kidney, close your eyes, think about the left side of the abdominal cavity and what organs are there and what could be touching or crossing over the kidney. So hopefully all of this is a review as you're going through it. Next, list the basics. The kidney has two regions, the outer cortex and the inner medulla. Hopefully you can easily see the difference between the two parts. And then, of course, I put a picture of your nephron for you in case you forget all your different moving parts of the nephron. So nephrons are your functional unit of the kidney. There's more than 1 million nephrons, so you need to know that. These are subdivided into two different kinds. Hopefully you remember juxtamedullary and cortical. So if you're looking at this picture right here, hopefully you can tell that with juxtamedullary, it's got to go all the way into the medulla. So if it dips low and it goes low into that medulla, it's juxtamedullary. If it stays superficial in the cortex, then it's going to be cortical. So cortical stays in the cortex, it's superficial, juxtamedullary dips down into that medulla. So hopefully that separates the two for you if you don't remember that portion. After that, know your other terms that are listed here on my slide. So know what each nephron is composed of. It's composed of a renal corpuscle and a renal tubule. So you can see both of those on this picture right here. The renal corpuscle is right there in the tubules. After that, the blood supply, you should focus on that. So blood supply, the renal arteries, not what they flow through, but how they are pictured in the body. The renal artery and the renal vein, as you see it in your picture right here on this slide. At the top of, still on page 818, the right side of the page. So again, talking about the blood supply, I will go back to finishing that part. So the renal arteries flow a transverse course from the abdominal aorta to the hilum of the kidneys. At the hilum, the arteries form multiple branches that enter the kidney, sinus anterior and posterior to the renal pelvis. So that's a lot of different words for you. What you need to do is read through it and kind of break it down. And like I said, look at your anatomy pictures as you are studying this. So know your arterial and your arteries and your veins that are connected to your kidney and how that blood flow is going to work. After that, it talks about simple nephrectomy, what it can be performed for. You should read through that too. Simple malignancies, obstructive disorders, tumors that are benign, and then removing the kidney for transplant. Okay, so as I said, you're responsible for everything in your book, so read through the rest of that, but I did want to hit anatomy a little bit on this one because the kidneys can be a little confusing. So let's flip it over because there's a picture on 8 and 19. Let's flip it over to 820. 820. Okay, so it's talking about what drains from where on 820. So the major calyces, and calyces is the right way to pronounce that, drain the superior, middle, and inferior portions of the kidney into the renal pelvis. Now, the little details in the middle don't matter as much, right? The calyces drain the kidney into the renal pelvis. So that's the part I want you to focus on. So the renal pelvis is located in the hilum of that kidney, and it goes all the way to that ureter. So hopefully these pictures on this page will help you out better understand these words on your page. So I won't read through the rest of this, but we're still on simple nephrectomy. So I want to point out some key things. So as I told you, position is key. So know your positioning for this case on page 820. It tells you it's in the lateral position with the affected side up. You don't want to mess that up and position your patient backwards. There are some cases where the surgeon will expect you to drape and everything before they get into the room. So when they scrub in, they're ready to make an incision. If they get to the operative site and realize, oh, you position the patient incorrectly, which means you also draped incorrectly, that's a huge delay in time. So now they have to take those drapes off, get you new sterile drapes, and redo the whole prep and draping process. So make sure you are paying attention to the positioning as you're reading through these cases. So anyways, after the positioning, let's look at practical considerations on page 821. So your practical considerations. They will have x-ray films in the room, so they can be properly displayed in the OR, and we can look at them during the case. It talks about if the kidney is intended for transplant. I want you to focus on that bullet point, your second bullet point. So the living donor may be heparinized several minutes before removal. So they are heparinizing the patient and thinning that blood out before removal. They're going to dissect all of their vessels and the ureter in a way that they have the biggest length possible. So anytime they make a cut, they want as long as possible, because you can always make it shorter, right? But you can't make it any longer than it is. So length is key. After that, you'll see an important thing for the scrub tech. The kidney is going to be infused with cold colloid solution. So that's going to preserve that kidney. It also provides renal cooling. So the kidney is infused with cold colloid solution. It's going to preserve it, so it's a preservative referred to as renal cooling. So the function we're doing with the Collins solution is renal cooling. Renal cooling is a technique used to preserve that renal function during an episode of planned or prolonged arterial occlusion. So you're thinking arterial occlusion, that could be just clamping it off, clamping that artery off. Any of the surgery that we're doing that can cause damage to that kidney. So that's why we're using the Collins solution, and that's why we're going to perform renal cooling with it. After that, on 821, still look at the right side of your page this time. Find again where it starts with renal cooling. So renal cooling reduces the metabolic requirements of the kidney and lowers the possibility of tubular necrosis. So those tubes can get crushed, and of course, if that tissue is crushed, it has no blood flow, it could die and necrose. So that is what they're talking about on that section. I want you to look at your next option. The surgical tech will need sterile ice slush along with a sheet of sterile plastic. So here's what I would like you to add into your book. Where it says the kidney is infused with cold Collins solution in bright purple, on the left side of your page, I'd like you to put number 1 next to that. And on the right side of your page where it says sterile ice slush, I want you to put number 2 on that one. What your book kind of doesn't say word for word is you can do one or the other. So you can do the renal cooling technique, or you can put the kidney on that sterile ice slush, and the ice is going to keep it cold. So those are your 2 options. So hopefully you put a number 1 by the Collins solution or number 2, the ice slush. Those are your 2 options on this one. Okay, and then the surgical procedure. So on 821, that picture at the bottom shows you exactly what they're going to be doing. So even though that's one small picture, you can see that they're going to clamp and cut that ureter, the renal vein, and the renal artery. That's what we're going to be doing in this case. So flip over to page 822. So on 822, again, I'm not going to go through every step because you're going to see it again later in multiple other cases, but look at your anatomy that you're hitting as you're cutting through. The anatomy is key, important. And then I want you to go down to number 9. So number 9, they start with the ureter. So the ureter is isolated, doubly clamped, transected, and ligated. So that means for you as a scrub tech, clamp, clamp, cut, tie. The same pattern, clamp, clamp, cut, tie. Hopefully you have that pattern memorized and you already know it, but a reminder for you if you don't, you should know that pattern. Anytime we're clamping a structure, a vessel, it's clamp, clamp, cut, tie on anything. Only time you have seen it in a different order is with bowel cases. It's 2 ties at the end. So clamp, clamp, cut, tie, tie. That's not much of a difference. So as long as you have more ties ready to go, you will be safe. So remind yourself of that pattern. Know it's the same even for a ureter as it's talking about on number 9. So after they clamp, clamp, cut, tie that ureter, you can look at number 10. They're going to retract that kidney so you can see the renal artery and renal vein. And then number 11, I want you to pay attention to which one they do first. So the renal artery is clamped first, and then that renal vein. That's the part I want you to focus on. Okay, after that, they talk about any remaining attachments being released and then removing our kidney. So hopefully you're seeing a pattern. The end of the cases are all the same. Achieve hemostasis, irrigate if we need to, and then close our wound layer by layer. Every time you're reading through these cases, I hope you are mentally thinking, this is when I would start counting. The second you hand that suture and the case is over, I'm starting counting. You always want to start with, on these open belly cases, the lap sponges that are in the belly. Because you're thinking about all of these big instrument trays that you have to count on this kidney case, but what could be left in that belly more likely is going to be a lap sponge. So you want to get those laps counted as soon as possible before moving on to bigger things. Okay, let's flip it over, 824. Not yet on the kidney transplant. So on 824, you'll see the position. It will hit that again for you. 825, it hits all the muscles that you cut through. You need to know those. So it specifically points them out for you. External oblique, internal oblique, latissimus dorsi muscle. Even reminds you that we're going over our 12th rib. So these pictures are going to help you study for this case. So please use these pages and the pictures. You can see it's the same steps I just went through. I don't think there's anything more to add. So I'm going to flip to page 828. 828, you see I'm closing up this case. So now you'll see a laparoscopic simple nephrectomy. So yes, we can do this case laparoscopically, but usually only if it's the simple version. So if it were, let's say, a radical nephrectomy, we may not be able to do that laparoscopically due to there not being enough space and enough room. Okay, so if they can do it laparoscopically, there is really just one thing I want you to add that's not in your book. It talks about it later, and I'll point that out on the next page, but it doesn't have it under your equipment and supplies, so I would like you to add it. The laparoscopic simple nephrectomy on page 828, where it says equipment, instruments, and supplies, I want you to add morcellator. Morcellator, and it tells you what it is on the next page. I will get to that. But it should be in your equipment, instruments, and supplies. You'll need this morcellator to basically cut up, morcellate those pieces of kidney because we're doing it laparoscopically. We're not going to be able to just take it out. The patient isn't open. We have to get it through a little port. So think about that, but add in your morcellator. For the rest of it, equipment, instruments, and supplies, it's laparoscopic stuff, right? You should already know that. So laparoscopic equipment, and then let's look at page 829. So notice in addition to all this laparoscopic equipment, we're gonna need a cystoscope and a ureteroscope. So if you're wondering, why do I need those things? Look at your last bullet point, the top of 829. Prior to the start of nephrectomy, a ureteroscopy will be performed to place a ureteral catheter. Notice that doesn't say urethral catheter, ureteral catheter. It's going in the ureter. And the renal balloon catheter. The 16 French Foley catheter will also be inserted. So it's telling you specifically they're going to get a ureteral catheter on this one. So that is the purpose of the ureteroscopy and the cystoscopy equipment. It's because we want to take a look before we get started on this kidney. So they're going to not only take a look, they'll be placing a ureteral catheter. Okay, the rest of it, make sure you read through it, of course, but we are accomplishing the same thing, but we're doing it laparoscopically. In fact, I will stop on page 830, look at number 11. You'll see again the renal artery and renal vein are identified and mobilized. Know which one is ligated and transected first. I won't repeat that for you. Know which one is transected first. Okay. After that, now you will see our magic word, the morcellator. So go down to number 17. This is what's very different with this case compared to the open one. So an electrical tissue morcellator is placed inside the sac and the kidney is morcellated using suction. So let me tell you what a morcellator does. You don't have to look it up, but you can, so you have an image of it. It's going to chop up pieces of the kidney and some of the ureter into small pieces so that we can suction it up. So it's going to morcellate it, and then we will suction that up. So once the sac is empty, it is completely removed from the abdomen. So once that sac is empty, we're able to fit it through the port and get our what's left of our specimen out. Okay, and then the rest of it is done like a normal laparoscopic case for closure. So that's all I have for you to add for your laparoscopic version. Add in that morcellator because we won't be able to fit it through that little trocar. We're gonna have to morcellate it into little pieces and then take out just the sac. Okay, I'm done with kidney anatomy and everything about nephrectomies. Let's move on to a really big fun case, kidney transplants. So I loved the rare times I got to do kidney transplants. They usually have a team of specific people doing it, so they have consistency. They have the same scrub, same nurse working on these cases. Before I get into this beautiful setup, I will look at some of your pathology. So on 831, of course, read your Pearls of Wisdom, very important, but I want to look at PKD. So know what PKD is, polycystic kidney disease. These can get really big and exaggerated if they're not taken care of early on. So know for PKD, let me find it. The cysts begin their formation in the tubular portions of the nephrons and enlarge substantially. So they enlarge very quickly. There's 3 different kinds of polycystic kidney disease. I want you to recognize all 3. So autosomal, the dominant PKD, is inherited. So your dominant autosomal PKD is inherited. Autosomal is a recessive PKD, other inherited form, and extremely rare. This one affects young children. So that's how you're going to separate this one from the others. So it's another inherited form, but it usually affects children. So autosomal recessive is the one that usually affects children. After that, acquired PKD. Acquired PKD means they've acquired it from their kidney pathology that they already have. So it develops in patients with long-term kidney disorders. Okay, and you can read through some of the different symptoms. I want to stop at diabetic neuropathy. So the main symptom is severely decreased or no urine output. So that's why keeping track of urine output throughout our surgeries is very important. So if you're in any case that has an extended period of time where a patient could need to urinate, or they just want to map the urinary output, they will have a Foley catheter. All right, so read through, if you don't remember, read through how diabetes mellitus can affect your body, especially your kidneys. So make sure you read through those bullet points also, even though I didn't go over them with you. Flip over to page 832. So I want to stop where it says this disease is progressive. So it's progressive. It can lead to chronic renal failure and continuing end-stage renal disease within 2 to 6 years. So it happens very quickly. Dialysis and kidney transplant may be necessary. So that's why PKD, we do see transplants for that reason. Death occurs from the accumulation of waste products and fluid if treatment is not started immediately. So we want to start treatment immediately for these patients. The only 2 treatments for ESRD are dialysis and kidney transplants. I want you to know both of those options. So your only options for treatment on page 832 are dialysis or a kidney transplant. After that, it goes into more details about ESRD, end-stage renal disease. So the final stages of many types of kidney disease that occur when the filtration of the kidney is no longer affected. A person is considered end stage when the kidneys are functioning at less than 10%. That's the part I want you to hit. So less than 10%, we consider them ESRD, end stage renal disease. Okay, let's look at living donor procedure practical considerations. Note that it says living donor. So there are different ways to do kidney transplants. Sometimes you really have a living donor in one OR who's giving up their kidney, and we are taking it to another OR in the same facility and giving them that kidney. I have never seen it done that way. All facilities are different on whether they do living donors or whether they just work with a company, example, LifeShare, where maybe there was an organ harvest done and now that kidney is up for someone who's been waiting on a list for a transplant. So it's a fantastic day for those patients. They finally get their kidney that they've been waiting on. So that would be working with LifeShare, and in that case, they are going to actually come into your room with the kidney in this machine. So this is going to keep it cold and keep it perfused throughout that time. So you can actually see your options right here. It's coming in a clear plastic bag. This is what it'll look like in a clear plastic container. Of course, it's all sterile on the inside, so it's a container within a container within a container, so that if we go to open it and we were to contaminate one layer, it's okay, we have another layer, because you can't mess up and contaminate a donated kidney. Okay, so again, living donor is what this section is talking about. So on this section where it says living donor, I want you to find in the center section where it says 2 ORs will be set up. So that's what I already told you. 2 different ORs are going to be set up for your live donor. I also want to look at that last bullet point. The Collins solution is not going to be used with the living donor. So Collins solution must not be used in perfusion for living kinder donor, because the residual perfusion solution could increase the serum potassium level in the recipient. So it's going to mess up their potassium levels, basically. So if their potassium goes way up, they could have repercussions from that, and we can't have that in an OR. We want to be in a controlled setting. We're in control of what's happening to their body as much as we can. So no Collins solution for your live donors. Okay, after that, it goes through our surgical procedure. So I will go back so you can look at the setup as I go through it. So I'm going to have you make a little note in here that says before and after. So on step 1, nephrectomy is performed on the donor. So we're still doing the live donor version. So we've got a patient in 1 OR donating a kidney, and this is the before section. So it says just before the surgeon clamps and divides the renal vessels, anesthesia is going to heparinize our patient. They're going to administer heparin and mannitol through the IV to promote diuresis and prevent clotting in the arteries and veins. So heparin and mannitol are going to be given to our patient. That's what's going to happen before we take the kidney out. So go ahead and make yourself a note next to that first purple bullet point on 832, put before. So all those drugs, heparin, mannitol, everything anesthesia is doing is done before we get the kidney out. Now look at your third bullet point on page 832. Now I want you to put after next to that. So after the kidney is removed, the anesthesia provider administers protamine sulfate to reverse the heparinization. You should already know this one from surgical pharmacology. It's a one that you need to memorize, because are you an anesthesia provider? Are you going to be pushing those medications? Absolutely not, but they will ask you those questions on your CST exam. I had many anesthesia questions on my CST exam, but luckily I memorized those medications and knew what they would use to reverse heparin. So you should already know protamine sulfate reverses heparin, but I was talking about this case specifically because we're going to be heparinizing our patient, not only through the IV with anesthesia, but on our sterile field, you're going to have some heparinized saline so that you can heparinize our kidney before implanting it. Okay, after that, and you've made that note before and after, let's look at page 833. So the harvested kidney is placed in a basin on the back table. That brings me here. Harvested kidney is placed on the back table that contains sterile ice slush, and it's flushed with an electrolyte solution. That electrolyte solution is a mixture of Ringer's with heparin, or commercially used, your Wisconsin version. You don't need to know that. What I would rather you pay attention to is your electrolyte solution, a mixture of Ringer's lactate, procaine, and heparin. So Ringer's and heparin are your main 2 on that one. Okay, you'll see the basin with the kidney is covered with sterile towels. The surgeon takes it to the recipient OR. So they're taking it over to the other OR to put it in. So now I can stop and switch to cadaver donor. So notice it says cadaver donor. Not really a cadaver yet, because our patient should be recently deceased if we are donating a kidney. So like I said, you will be working with a company like LifeShare, like we have here in Oklahoma, and they will help you with the setup and everything. They have people come in to bring the kidney in this machine usually, or on ice, as you see on the right side of your page. So they have different options, and they've got high-tech technology now So if they can, they will put it in this perfusion box and they will perfuse it so it constantly has fluids and blood running through it. So that way, when we implant it in our patient, it has a much bigger chance of surviving and working on our patient. We've come a long way with technology. So looking at your cadaver donor on 833, I want you to read through the options here and understand what a cadaver donor is. What's important here is that these patients can't have any infections or any cancers, or we can't take their donation. With the cadaver donation, I want to point out it's not 2 ORs. It's 1 OR. LifeShare will bring in your kidney if that's who you're working with, if you're in Oklahoma, and then you can just transplant that new kidney into our patient. So that's what's going to be different with our cadaver donor patients. If you'll flip it over, I'm going to skip over page 834 and go to page 835. 835. So I want to point out on the surgical procedure, this is the recipient procedure. So it's just the recipient. So let's talk about donor kidney implantation. So I want you to look at 835, number 2. Number 2. So in an adult, the donor kidney will be placed in the right pelvis. Therefore, the surgeon uses a Gibson incision. So it tells you in pediatric patients they could do midline, but I'd want you to focus on the adult cases because that's where you're going to be doing more kidney surgery. So for adult cases, know that they're going to use that Gibson incision. Okay, after that, it goes step by step what they're going to do. I want to skip to the good stuff after we've dissected down and mobilized our arteries. Let's go to number 5. So everything has been mobilized, vascular clamps have been placed, all that good stuff. Now we're ready for the big moves. So on number 5, the internal iliac vein is going to be ligated and divided. The surgeon is going to use a number 11 blade to make a small venotomy. So 11 blade to cut into the vein between those clamps. The vessel is going to be irrigated with heparin sodium, so that's heparinized saline, using a bulb or a septo syringe. After that, next important surgical tool, 45-degree pot scissors are used to extend that poke hole incision you just made with the 11 blade in preparation for the anastomosis with the donor kidney renal vein. So that's a lot of information. I'm going to have us go back through and add some stuff in. As I went through that number 5, I hope you're thinking, I'm the scrub tech, what do I need? So what do I need as a scrub tech? 11 blade and then pot smith scissors. That's what I want you to focus on the most. 11 blade and then pot smith scissors. Now let's read through that last sentence again after the venotomy. So 45-degree pot scissors make a venotomy, so extend that poke hole incision in preparation for anastomosis into the recipient. I want to point that out. Anastomosis with the donor kidney renal vein, the anastomosis is into the recipient. Into the recipient. Okay, after that, let's look at number 6. The surgeon or the ST places the donor kidney into a stockinette. Here's what I'd like you to add on that stockinette. The stockinette that you're holding actually looks similar to what is around this kidney right here, which means it is woven. It's not really like other stockinettes we use in orthopedic surgery. It's a woven material that looks just like this bag right here that's inside your kidney perfusion machine. So on that stockinette, I'd like you to make yourself a note. It's a woven stockinette. So the surgeon or the ST places that kidney in a woven stockinette that's been soaked in that electrolyte saline solution. And you'll see if you don't have one that's woven, holes are cut in the stockinette and the renal vessels are brought out through them. We're just going to use a woven one that already has holes, and then the vessels can be brought out through those holes. That's the notes I want you to make for more realistic studying. Okay, look at your procedural consideration. The stockinette aids in keeping the friable kidney tissue from being injured by the people in the OR. So this helps us not be so rough with the kidney. After that, you can look at number 7, that donor kidney renal vein is going to be anastomosed to the recipient's internal iliac vein. Those are the two I want you to match up. So renal vein from the donor, that makes sense, right? That's the main vein that comes off of your kidney. So renal vein is anastomosed to the internal iliac vein, major vein in our body. In any anastomosis, I hope you are catching on to a pattern here. We don't need to focus on the size of the suture, right? 5-0 or 6-0, we know it's going to be very small for anastomosis. The part I want you to focus on is it's a double-armed polypropylene suture. So double-armed Prolene suture. So we always use Prolene for anastomosis. They're always double-armed, and they're always a very small size. So 5-0, 6-0, 7-0 if we're really getting small in heart surgery. I want you to catch that pattern every time you're reading through a case that has an anastomosis. You should already know, I know what they're going to anastomose that with, and I'll have that suture ready. Okay, after that, let's go down to number 8. It's talking about the anastomosis being done, but I want to look at the procedural consideration. Procedural consideration, the surgeon places that final stitch in the anastomosis. The ST should remind the surgeon to irrigate the vessels with heparin sodium. Now it says they can do it with a 10 ml syringe and a catheter. That's because that big asepto bulb won't fit in there anymore. It's just a little vessel. So we're gonna have a little catheter on the end of a syringe so we can irrigate that through. And that is your job as the ST to remind your surgeon of specific steps, especially on big cases like this. Okay. I will not read through the rest of those steps. You can read through the rest, very repetitive, but there's a great picture for you on page 836 so you can see exactly where they are sewing it back together to stay in the recipient body for kidneys. On 837, top of the page, you will see what they're going to do at the end of this case. So number 13, a ureteral stent is inserted through a, ready for this word, ureteroneocystoscopy. So this one is up to the renal pelvis and through the urethra. So this stent is going to stay in place for about 2 days. Know the purpose of a stent. The whole purpose of a stent is to have that patency remain. So if you have a tubular structure, like a vessel, a ureter, anything like that, artery or vein, it needs to stay patent to stay open. So if it starts closing up, the only thing we can do is put a stent in there. So a stent sometimes is like a cage that's going to open up and keep that vessel wall open, because now it doesn't have a choice. The stent is forcing it to stay open and to keep that tube open. So that is your purpose of putting in a stent on that case. You can see number 15, ureteroneocystostomy is irrigated and visualized for leaks. So you need to recognize that word. You won't be tested on that pronunciation, luckily. And you need to know that they're going to be putting in a stent, a ureteral stent. In fact, if you need to make a note by our big word here, one more time, ureteroneocystostomy. Next to this one, you can make yourself a note. Med term 4, procedure of connecting a donor ureter to a recipient bladder. Procedure of connecting a donor ureter to a recipient bladder. That's switching it to layman's terms for you. And I think that is the end of my kidney. So I will go back here for just a moment. Look at all those instruments you have to count the second you hand them a stitch. So just like the book Walter, they're going to take that out, hand it back, and ask you for a stitch immediately. So as soon as they start closing, you got to count all of these countable items, instruments, laps, even all the little bulldog clamps, all have to be counted before they get to skin. So think about how you're moving in the lab and think about how you can speed up your process. Everything is going to be about speed, getting it done faster. Okay. So you'll see they need a major tray, self-retaining retractors, vascular clamps, bulldogs are your little vascular clamps. You can actually see your bulldogs on page 836. They are clamped onto those vessels. And then of course the slush machine that I've been talking about. So this has a sterile drape and actually moves the slush up and down. so it doesn't come into hard pieces of ice, sharp, jagged edges. It's all a nice slush the whole time. Got a little margarita machine in the OR making your slush for you. And then this part I added in for you so you will know that if you ever get to do a kidney transplant, sometimes they're going to call it back benching or a back table that's prepping the vessels for anastomosis. So if they get that kidney out, they want to prepare it. They want to get all the vessels pulled out. There's lots of extra tissue and fascia attached to it, and they don't want that in the way, basically. So they are going to prep the kidney so that it's ready for that anastomosis when they get it in the belly. And then, of course, I showed you your options for how they're going to bring the kidney to you if it's not from a live donor. And that brings me to cystoscopy. So GU endoscopy, AKA cystoscopy. Cysto room is what you're going to hear a lot. They usually have a designated room just for cystoscopy. So GU endoscopy, look at your second paragraph. The urinary tract endoscopy is commonly referred to as cystoscopy. So we're going to be looking and viewing inside the bladder. I want to point out that it's not only viewing. So the main purpose of urinary tract endoscopy is diagnosis. Yes, we're going to go in there to just view and diagnose, but look at this pictures I got over here. If we have a bladder tumor, we're not going to be just viewing, we're going to be removing that bladder tumor. Look at all these bladder stones, we'll be removing those stones individually too. So keep in mind, if you're just viewing, it's a diagnostic. It's not a real, I hate to say not a real surgery, but you're not taking any specimen out, you're not counting any instruments, you're not doing any of that stuff, you're just going in and viewing. So think of that as a student. If you do these cases, they're still great for learning, but you're not gonna get full credit for that. You're not counting any instruments, you're not counting any sponges, none of that stuff. You're just going in and viewing. So it's going to be accounted for differently when it comes to your extern hours. You always want to try to get in on bigger cases where they're going to be actually taking specimens out. Okay, so endoscopy, you know, it's a diagnostic. Look at all your bullet points underneath GU endoscopy. Read through all your bullet points, know the different options, what they're going to do, but biopsy, retrograde urogram, visually diagnosing is a big one, as you know. And then look at TURP. We're going to be doing lots of TURPs, prostate tumors, and then lots of TURPs, TURBTs. So on this one, know the BT stands for bladder tumor. We're actually going to go at it the same way to remove it. So hopefully you can see this ring right here. We have our electrocautery ring out here on the table today, but this ESU ring allows them to use cautery to just cut that bladder tumor right out. Our bladder is going to be full of irrigation during our cystoscopy. So when we're done, we just irrigate that bladder out and all of our specimen comes out for us. So know that your TURP and your TURBT, very similar as far as the hands-on part of the case, very similar. After that, you'll see placement of ureteral stents on both ureters and then calculi being removed. So know your name for your stones, your calculi. Okay, now let's look at page 838. I want to go over the fact that endoscopy, it's not going to be sterile. So we're going to treat it as a sterile field. We're going to create a sterile field, open it properly, not contaminate it, but it's not really a sterile procedure. So look at your second paragraph on 838. A sterile field must be created and maintained. The surgical tech is not required to scrub in for endoscopy. So this will really throw you off the first time you see a scrub tech just open glove. So their gloves are still sterile, but they're not going to put a gown and gloves on. They're just going to come up to their table. And of course, they're going to back up as much as possible. You're not going to push your scrubs up against your table and contaminate it by any means. You're just going to set it up with just gloves. Because it's not a sterile environment, there's no reason to stress on making sure everything stays sterile. Now, I would still replace anything if it gets contaminated, but the idea is you don't have to scrub in. So hopefully you highlighted that portion. It says on your second paragraph, not required to scrub in for endoscopy. If you read further down, you'll see you're going to don sterile gloves, you're going to use the open gloving technique, and organize your back table. Now, when it comes to actually doing the procedure, it depends on how involved it is, whether you're going to want to put a gown and gloves on. If you're going to be really hands-on, working with those instruments, you're going to want a gown and glove regardless. But no, for most cystoscopy cases, we will not be scrubbing in technically. You'll just put on sterile gloves and set up your sterile field, making sure to not touch your sterile fields. Okay, now look at all your bullet points at the bottom of 838. The positioning is very important, and you will be assisting the surgeon a little bit more on these cases. If you are not scrubbed in, as I said, you just set up the sterile field using the open gloving technique. If you're not scrubbed in, you'll be expected to do more circulator duties. So when the surgeon tosses off the camera and the light cord and all those cords, you'll be plugging them in. So if they don't need you scrubbed in, you need to be doing something else. You need to plug in those cords for your circulator so that they can do their charting. Okay, after you read through all of those bullet points, I want you to look at the top of the right side of the page. So again, this is when you're not scrubbed in, you're out there, you're watching the surgeon do the case because there's no reason for them to have a scrub tech on this example. So main role of this ST during endoscopic procedure is to be certain that the irrigation fluid is constantly available and does not run out during the procedure. So this isn't like an annoyance of they don't want to run out of fluid. This is important. It changes their view of what they're looking at because, as I said, the bladder is filled with water this whole time, right? That irrigation fluid has it filled with water so that we are able to put our scope in and see. But that irrigation fluid, if it runs out and restart, it creates a huge amount of bubbles. And I've only seen this happen once, and you'll hear a lot of bad words come out of your surgeon's mouth. So they're in here trying to find a bladder tumor or a stone or whatever it is, trying to remove it. And then their view gets totally ruined by a bunch of bubbles coming up. So they cannot have that during the procedure. You need to know that portion. And then on the next paragraph, you'll see urinary catheters should be available because at the end of these procedures, that'll usually be that last step, putting in that catheter. Now look at CBI. CBI, I want you to look through that whole paragraph and memorize that. So CBI is continuous bladder irrigation used after TURPs or TURPs. So on both of these cases, you'll need a 3-way Foley catheter. You can make that note. And that allows you, that third valve allows you to irrigate this bladder. So it allows you that CBI, continuous bladder irrigation. Okay, after that, you'll see any specimens should be transferred from the sterile field and properly labeled. The ST should take care not to place bladder, ureter, kidney stones in formalin. So reminder that formalin will dissolve the kidney stones. So don't use any formalin on your specimens in cystoscopy. Okay, after that, we can go to ureteroscopy. So ureteroscopy, I've got a good picture of the setup here, but I want you to look at the, I want you to look at the pathology first. So I was going to skip to your instruments, your pathology. So I want to stop on 839 where it says calculi. So calculi or stones are solid particles that may form in one or both kidneys. I want you to know that it's going to originate in the kidneys. So add that word in for me. The calculi, these stones, are going to form in one or both kidneys. So they're originating in the kidneys. After that, you'll see for pre-op, they're going to do x-rays, ultrasound, urinalysis, of course, to figure this out. And now look at your equipment, instruments, supplies in the room. So your ureteroscope is going to be long, so you can get up the ureter. Cystoscope is going to be shorter because you're just going to the bladder. So now you can tell the difference between the two. Van Buren urethral dilators, you should be able to recognize that instrument. And then your basket stone forceps. So this one is just a handheld instrument that's going to allow you to catch these stones. So what I have out for you in the classroom, these small like guide wires, they also have a basket that will go down just like those guide wires. So it's a nice thin wire that goes down into our scope. You'll see it pop up on the screen after you insert it, and you will gently open and close this for the surgeon. Most of the ones I use just had a button at the top. So you'd open and close it for them. So it allows them to catch those stones, and then we can pull that guide wire out and get our specimen out. So basket stone forceps, make sure you know that you need that. And then in addition to that, look at your ureteral stents. It says JJ ureteral stents. I want you to have another term for this because more likely they're going to call it a pigtail stent. So JJ ureteral stents or a pigtail stent. Okay, so you know you have your basket forceps. That's your special item for this case that's going to allow you to grab the stones if needed. Look at your positioning. It's not just lithotomy, it's in low lithotomy. This allows better positioning for the surgeon and the scrub tech really, so that we can get those stones out and get in between the legs in that position to do the work that needs to be done. So low lithotomy. Another reason low lithotomy, look at your practical considerations. Fluoroscopy is going to be needed in the OR for this one. So you'll make sure that you're wearing lead and that your bed is positioned for fluoroscopy. Okay, I want to look at the surgical procedure and read through it. So on 839, surgical procedure, surgeon dilates the urethra for insertion of the cystoscope prior to insertion of the ureteroscope. So that means anytime you're doing a ureteroscopy, you're going to start with the cystoscopy. So you're going to start with the shorter scope, looking in the bladder. Take a look in the bladder, and then we'll switch to the longer scope to look at the ureter. Okay, then look at number 2. The ureteroscope is inserted in the urethra, slowly advanced into the bladder, and then into the ureter. So the ureteroscope is advanced in the ureter up to the stone. So we don't advance any further than we need to, is the purpose of mentioning that. They're going to go up to the stone, they see it, they'll send the basket forceps in, have the scrub tech grab it, pull it out, and now you have your specimen. So that was, I already talked through it. Number 3 on page 840, insert the basket stone forceps down the port of the ureteroscope and then capture and remove that intact stone. Now, if the stone is really large, look at letter B on 840. If the stone is really large, they're going to have to break it up with a laser. So you saw your small laser fibers, you'll thread one of those through to your surgeon, and then they will use the laser to break it up into pieces. Very powerful. It will kind of pulverize these stones sometimes, so little particles of it disappear, but the rest is broken into smaller pieces, and now we can remove it. So after we've removed our stones, look at number 4. After it's removed, the JJ stent or your pigtail stent is inserted. So again, stents are to keep patency, to keep that ureter open. So instead of letting it collapse after doing this surgery, it's going to help keep it patent and open. Okay, I want to, at the bottom of this one on your prognosis, I just want you to see that for everyone it's a little bit different, but removal of that stent is going to be from 3 days to several weeks. So every patient is different and every doctor is different. So that's a wide range. So that stent's going to stay in from 3 days to several weeks. Okay, that's all for that one, ureteroscopy. I'm going to go on to pileolithotomy. So pileolithotomy, I want to take a pause for this one because I want to look at your, there it is, your positioning. So on page 841, look at your positioning. So pileolithotomy, we're going to be lateral with our kidney rest. So we're making a big flank incision on this one and we're cutting into the belly. So no more cystoscopy. We're cutting in to look at a kidney stone. So if that kidney stone is lodged in the hilum, basically, then they're going to go in and remove that calculus. So you'll actually see it on page 840, your very last bullet point. Pileolithotomy is excision of a calcus from the renal pelvis. So specifically, that stone is going to be lodged in the area of the hilum. Okay, the large incision, I want you to look at the last bullet point on 841, same as a nephrectomy. So that's why I'm not going to read through that one. Very similar to the procedure done in a nephrectomy. Okay, now it switches back to real cystoscopy for a moment, and it goes into a TURP. That's a bladder tumor. So for one moment, I'm going to look at our TURP. So this, like I said, is for prostate tumor, right? It looks like and is just like this bladder tumor case. So let's look at your book first, page 842, cystoscopy. So look over your anatomy, know your different muscles. Let's look at the detrusor muscle. The detrusor muscle is responsible for both emptying the bladder and closing the bladder orifice. So very important muscle. You want to know that one. For this one, know that bladder cancer is common, first of all, and you're going to be doing a lot of these cases if you're working in cystoscopy, but bladder cancer has a tendency to reoccur. So these patients are going to do a lot of follow-up to make sure their cancer doesn't reoccur. And you will, if you work specifically in cystoscopy, you'll see repeat patients for that reason. On page 843, I want to look at the male specifically. So in the male, the bladder lies on and is attached to the base of the prostate gland. Now in females, the bladder lies on the pelvic diaphragm. So that's why we can have urinary incontinence with women, but with men, it's attached to our prostate. So I'm pointing that out so you can see, even though we're going over a bladder tumor, it's the same as a case for a prostate tumor. We're still going to take away that pieces of tumor the same way. Okay, now look at preoperative diagnostic tests. A cystoscopy itself is a diagnostic procedure, but as soon as you take any tissue, perform any biopsies, take any stones out, put in a catheter, it becomes not a diagnostic test. Then it's an actual procedure. I wanted to point that out for you. Again, that will be key when you are externs, because it will determine whether that's a scrub 1 roll, which you need lots of, or a scrub 2 roll, which means you're not counting anything. Maybe you held retractors, but there wasn't any actual procedure done. You didn't take any tissue out. So that would get you an S2 roll, which you don't need a whole lot of. We can observe and assist all the time. We want all the S1 rolls where we're doing all the work, passing all the instruments, and counting all your countable items for the case. Equipment, instruments, and supplies, rigid or flexible cystoscope. So you'll be using a cystoscope, and again, we're going to be taking off chunks of that bladder tumor. So your position is the same, low lithotomy. Let's flip over to page 844. So because they're in lithotomy for a long time, you need to make sure they're padded really well. That's for all of these cases, but I wanted to point it out here because that's where it talks about it. So read through that first bullet point and you can understand the importance of padding and positioning. Then find where it says irrigation solution. So your irrigating solution should be non-electrolytic and isotonic. So examples are glycine, sorbitol, or water. Glycine is used constantly on cystoscopies. So this procedure is an example of a cystoscopy plus. So cystoscopy plus, we are removing this bladder tumor. Okay, and then on cystoscopy, underneath that portion about the irrigating solution, your middle section, I want you to find the one that starts with instruments. The instruments and endoscopes should be at least undergo high-level disinfection with 2% glutaraldehyde. It says, however, some healthcare facilities may sterilize these cystoscopes. So that's telling you because it's not a sterile procedure, they don't have to sterilize it. I will tell you, any hospital I've worked at, their manufacturer instructions are going to tell them to sterilize the equipment, not just do high-level disinfection. So it is the norm to sterilize these instruments, even though they're not going to be used in a sterile fashion. Okay, I will not go through this whole procedure. I want to point out a couple things. The setup does look pretty good. With any of these cases, you're going to dilate. So look at number 2. The urethra is dilated with urethral sounds or dilators. You always want to have KY jelly lubricant ready for your surgeon. So you're going to dip it in that lubricant before passing it over. In case you're not going to be the one passing it over, you're going to have them all laying on that jelly lubricant. If they have any residual urine that comes out, they're going to want to measure that in a graduated pitcher. So sometimes you'll have to quickly grab something so you don't get any urine on the floor and you catch that specimen. A reminder, we're going to be using inflow and outflow for irrigation on these. So because of that, you want that to flow into the bladder gently. So because of this, you'll have a stopcock on either side of your cystoscope. This allows for inflow and outflow throughout the case. So now we can track our fluids well, and we can keep the bladder filled with liquid. After that, you can look at page 845 at the top of the page. Look at your picture. So you're going to see how this is set up and how they're able to take out either a bladder tumor or a prostate tumor from this exact same view. After that, on page 845, you'll see that they're going to use a resectoscope with an ESU. It doesn't say this for you word for word, so I want you to add it in. So look at your first sentence. Because of the transurethral resection of bladder tumors, TURBT, that's going to be the same as your TURPs. So same setup, same picture for these. So an overview of the TURP is going to be provided in the details, and the description of the TURP procedure is the same. So that's why it doesn't go through all the details to see the differences and the similarities. It wants you to read through that yourself and find them. The instruments that are going to be added to cystoscopy setup include the resectoscope. So here where it says resectoscope, I want you to add one little thing. ESU. So it tells you they're going to use cutting loops. Right there, you want to add ESU because that cutting loop is only done with electrosurgery. So monopolar, we're going to be cutting those pieces of tumor out. So instruments to be added to cystoscopy setup include resectoscope, the sheathy obturator, the working element, and the cutting loops. And if you don't remember what those cutting loops look like, I have them here in the classroom for you to look at. I also want to point out on 845, top of the page, sterile water is going to be used for irrigation on these cases. If the bladder tumor is malignant, those cancer cells can be spread that way. So we want to prevent that by using water instead. Okay, on your last paragraph, know that cystoscopy is usually done very quickly. So there's not a lot of countable items here, but it's done very quickly and you want to think, I need to have everything ready to go and have it ready in the right order. At the top of page 846, you'll see another reminder. The actual tumor is going to be removed with the cutting loop. So the cutting loop is going to be attached to this resectoscope and allow you to take off big chunks of this tumor. What I want to add in is that you should go and watch a YouTube video or a JOMI video of them removing either a bladder tumor or prostate tumor so you can really have an idea of what this is going to look like. Okay, after your cutting loop, I think that's what I have for your TURP actually. So I think I'm ready to move on. So our ileoconduits. Ileoconduits on page 846, a cystectomy is going to be the removal of the bladder. If we remove the bladder, we have to have somewhere for that urine to go. So because of that, we're going to do an ileoconduit. So your procedure says radical cystectomy with ileoconduit, male patient. It is a little different with males and females. I want you to, instead of going into the procedure, go to the top right side of the page, last paragraph. The patient's going to wear an external stoma bag for collection of this urine. So you can see right here where that stoma is going to be, and they're going to have a bag just like a colostomy bag, but it's going to be filled with urine instead. So a final, more difficult accomplished option is the content urinary reservoir. So this is referred to as a conch pouch. This is fashioned and reconfigured bowel to serve as a holding area for the urine. So a lot of complicated words to tell you that they are going to get the ureters and connect it right here to part of the ileum, part of your bowel. And then you'll have a ileostomy come out, just like a colostomy or similar, and that bag's going to collect all of your urine. So it's a big involved case, but you see the end result is actually pretty simple. We're redirecting your ureters somewhere else, so the urine has somewhere to go. So your radical cystectomy with ileoconduit. So let's look at equipment, instruments, and supplies. So extended electrocautery tip, that means an extender Bovie tip, so it's nice and long so we can work inside the belly. After that, look at your hemoclip pliers and your stapling devices. So I'm pointing those two out because it's a very vascular case, so lots of hemoclip pliers. And then you're still working on bowel, even though it's not a general surgery case, you don't think you might need it, you're working on bowel too. You're anastomosing these ureters to that ileum. So you'll need stapling devices for the bowel. Okay, this one is a big case. You will want to read through it step by step. I want to point out just some anatomy. So on page 847, long vertical, big incision, the bladder is going to be exposed. We're going to put lots of moist laps inside the belly. If you have a big self-retaining retractor, which you probably will, like a Bookwalter, they like to roll up those lap sponges and have them moist and put them on the side walls to kind of prevent damage from those retractors. Then look at number 3. Number 3, so specific ligament. The urachus, a connective tissue that forms the umbilical ligament, is going to be clamped and transected. The proximal end is ligated and that large clamp is going to remain to be used for traction. So just that anatomy is what I'm pointing out to you on number 3. Now after that, you'll see if they're going to remove any lymph nodes, that's what they're going to do next. So it says lymphandectomy, that's removing lymph nodes if needed. After that bladder is free from its attachments, then the bladder can be removed or retracted out of the way. Let me flip over to page 848. So on 848, look at number 11. The ureters are going to be isolated and dissected back, but a segment of these ureters, specifically the proximal portion of the ureters, is going to be sent for a frozen section. So we want to make sure before we make this big move that there's no malignancies present. So if you want to make yourself a note on the side, it says to determine if surgical margins are free of malignancy. The term you're going to hear is to verify clear margins. So if you need to rewrite that in my words, to verify clear margins. Okay, so because of that procedural consideration, prepare to accept 2 specimens for frozen section. So make sure you label those correctly so that if they do find a malignancy, it can be taken care of correctly. Okay. The rest of that, all these steps, I'm going to skip a little bit. Let's go to page 849. Look at number 23. So your procedural consideration. Stapling devices may be used to divide the mesentery or routine clamp, clamp, cut, tie system. So old school doctors, clamp, clamp, cut, tie, tie. And a newer doctor likes to use those stapling devices to work with the bowel. So just like in general surgery. Then look at number 25. So once they have implanted those ileal segments, then the stents are going to be placed if necessary. So if they think those tubes need to stay patent and stay open, that they might collapse, then they're going to put a stent in to keep it open. And then you've got a good picture of what it really looks like when those ureters are implanted into the ileum. On page 850, if you flip it over, you'll see your end ileostomy. So this has to come out of the patient somewhere, right? So we can collect our urine. So right here is where it's going to come out every time. This is called an end ileostomy. So they'll make an abdominal incision, a separate one for this stoma. The ileum is going to be brought through that abdominal wall, and the edge is used to create a stoma. So they use suture, they invert it, and they use suture to suture all the way around. So think about what we're doing. We're taking a piece of dirty bowel and we're suturing it to the skin so that it can collect that urine throughout the case. Anytime we're doing that, just like with a colostomy, we have a high risk of infection. So keep that in mind. So looking at number 27 on page 850, the distal end of the ileum is brought through the abdominal wall at a predetermined location through a separate incision. So I want to point out you're going to want a skin knife, a clean skin knife, followed by cautery to make this stoma. Okay, after the stoma is created, then your procedure is actually done. So long, drawn out procedure, but very cool that we're able to divert that urine elsewhere in the body, just like we do with our bowel. Okay, that brings me to our next section, page 851. So these are procedures for stress incontinence affecting women. So this is kind of what I was talking about in class, that things can be GYN and GU. So this is a great example. It's GYN and it's GU, but it's mostly affecting the bladder. So it's going to be done by a GU surgeon. So for, again, urinary stress incontinence, the objectives are to restore the posterior urethrovesical angle and elevate the base of the bladder. I want you to know that sentence, because you can tell just by looking at these pictures, that piece of tape, the sling, the bladder sling is going to pull the bladder up, right? I want you to know the technical terms in your book. So the objective is to restore the posterior urethrovesical angle. That angle is important, and elevate the base of the bladder. You can see they're elevating the base of the bladder so it's not hanging too low anymore. This can be distorted from childbirth or just results of aging. After that, you can see on the right side of the page, significant incontinent episodes may be eliminated with a suprapubic vesicourethral suspension. So the name of that surgery, MMK. So the MMK procedure is performed by a GU surgeon or a gynecologist, sometime with an abdominal hysterectomy. So that's a really big case, meshing all those things together. Here's the note I would like you to make. This MMK procedure, your Marshall-Marichetti Krantz procedure. No one's going to call it that, first of all, so MMK. But I also want you to write down that this is the traditional version. This is the traditional version, or you could just say the old school way of doing things. What is more common now is on page 854, so we're going to skip. Page 854. So on 854, you see this pubovaginal sling, so the suburethral sling. This is more of what we are doing now to fix this issue. So on this part, I want you to see where it says surgical elevation and stabilization techniques. Those are both used at the top of that paragraph. These particular patients have severe stress urinary incontinence. Very specific, severe stress urinary incontinence. And then I want you to see the name of this tape. So you'll read throughout your book and it'll say TVT. TVT. So that's the actual tape, the mesh, the tape or sling as they call it. So tension-free vaginal tape, that's why it's called TVT, tensional-free vaginal tape, is a polypropylene mesh tape. So polypropylene, hopefully that's ringing a bell in your head. It's Prolene, just like Prolene mesh in general surgery, just like the Prolene we use to anastomose vessels. So polypropylene is what it's made out of, and you need to know that. So again, this is to suspend the bladder. So there's other bladder suspension products, but this is what I wanted you to focus on. So let me flip back for just a moment. So flipping back to page 841, MMK procedure is the traditional version. This is our traditional way to suspend the bladder. Look at page 853. So MMK procedure, suprapubic vesicourethral suspension with suture fixation to the Cooper's ligament. Very specific right under that picture. That's what I want you to know about MMK. More importantly, I want you to know on page 854 what we're doing now. We're using TVT polypropylene mesh to lift up that bladder. Okay, so that actually brings me back to TURP. So with TURP, I stopped at this before because it's just like the same setup for a bladder tumor. So the TURP, the male urethra passes through the prostate gland. That is some anatomy that I want you to know. So if that's not enough for you, I want you to add in the bladder attaches to the prostate gland. Now, your prostate gland, hopefully you remember it's divided into 3 different parts, and you need to know the 3 different parts: prostatic, membranous, and spongy. So read through your anatomy, try to remind yourself of it. On page 855, it talks about how many lobules, there's 50 in this gland. It also talks about some pathology. So on pathology, I want you to pay attention to BPH, benign prostatic hypertrophy. So this is considered to be a normal part of aging, but it affects most men over the age of 50. That's what I want you to see. You can add yourself in a note for benign prostatic hypertrophy. This is a common diagnosis of patients needing a TURP, so a TURP. Common diagnosis for patients needing a TURP. Okay, the rest of that anatomy and pathology, you can read through. I hit the main points. I want to flip over to page 856. 856. So find where it says resectoscope at the top of the page. So again, I want you to put this as that loop electrode. Loop electrode. This one, it does tell you it's using high frequency ESU cord, but you gotta have something to connect that cord to. So ESU loop electrode. So same thing that we're using on the bladder tumors, that little loop that's gonna cut the pieces of tumor out. Now, big portion, the end of the case, the catheters. So same section, I want you to see your irrigation used is sorbitol or glycine, so same as before, surgeon preference. After that, I want you to see 3-way Foley catheter. So the 3-way Foley catheter is needed to irrigate the bladder after this prostate tumor is taken out. So the idea is we're taking big chunks of the prostate out piece by piece, but it's all just filled in the bladder. It has to have somewhere to go. So we have to irrigate that out. And we do that in the operating room, but we want continuous irrigation. So that's why they're getting a 3-way Foley catheter. You saw today that there's usually an attachment so you can fill up your Foley catheter. In addition to that, this one needs irrigation. So 3-way catheter for irrigation. After that, look at your practical considerations. You should know those first 3 bullets very well. Read through them all. I've hit some of that already, so read through them all. I want to point out on that second bullet point, the E-lick evacuator. So this is one you're going to have to refill over and over again. And I actually have it here with me. So this is your E-lick catheter. There's a specific way to fill it up so it stays filled with irrigation, but they can bring it up and irrigate all of that specimen out of our patient. Okay. It talks about the different types of resectoscopes. I don't want you to memorize those names, but I want you to be able to recognize them. So Baum, Rocker, Iglesias, Stern, McCarthy, and Nesbitt are all different types of resectoscopes. More importantly, I want you to know which cases need a resectoscope. So out of these cases, we've learned our TURP and our TURBT, the bladder tumors, all need your resectoscope. Okay, on this one, there's a special note for you. So look at the center section of bullet points, last one. A sudden jerk of the patient's leg is an indicator that electrical stimulation from the electrocautery is irritating one of those nerves. So that could be perforation of the prostatic capsule might be imminent. So they don't want to perforate through that capsule. So if you at any point see the patient's legs jerking or moving, you should say something. That's your job to tell them so that they can talk to the anesthesia provider. Okay. I will look at page 857. You'll see they're going to start the same way with those Van Buren sounds and dilate the urethra. Go down to number 9. Once they provide exposure and they get in there, you'll see they're going to use a loop electrode to resect the tissue. So you can make yourself a note next to that, ESU. They're going to use the electrosurgical unit, just like our Bovie, like we use on most open cases, but we're going to use a loop electrode to resect that tissue. On page 858, you'll see a picture of that loop and what it's going to look like from your view. On page 859, you'll see number 10. They're going to use that ELIC evacuator that I was just talking about, your ELIC evacuator, or a Toomey syringe to remove that resected prostate tissue. So hopefully you know now that if it says it twice in your book, it's very important. So know your two options, ELIC or your Toomey syringe. And if you look at your procedural consideration, it talks about moving quickly, but it doesn't mention that some of these are glass. This is one that I have that's plastic, but know that this could be a glass option and you need to be very careful with it. And then number 13, make sure you read through that. You don't want any blood all over the Foley catheter or any of that stuff at the end of the case. I want to point out again, it's a 3-way Foley catheter that's going to be placed. Look at your post-op care. The patient's going to be transported to PACU. The urine in the Foley bag should be really visualized on these cases. We're looking for bleeding. And then you'll see your wound classification has changed. It is now clean, contaminated, or unclassified. Okay, the next one, page 860, you'll see that they can do this robotically. So if they want the precision that the robot provides, or if they just want to approach it a different way, maybe they can't get at it to the urethra, maybe it's too enlarged, then they will actually go through it, get to it through your belly and do a laparoscopic version. So laparoscopic prostatectomy, very common procedure. As you know, robot is a very big laparoscopic case, so I will not go through that portion. Okay, next you'll see a suprapubic prostatectomy. So another way to do a prostate through the belly, but not laparoscopic, just open. So we are doing this case open. So suprapubic prostatectomy, know some of the equipment that they'll need. Equipment, instruments, and supplies. Self-retaining abdominal retractor, and this is one you haven't heard of before. So the Judd Mason retractor. Know that name and know that it matches up with the suprapubic prostatectomy. Very similar to a Balfour retractor, but it's specific for GU. They also are going to be using a suprapubic catheter on this one. So Mallinckrodt, a Pezzer, or one that's not listed in your book, Ben-Ana. There's lots of different brands and names for these catheters, but Mallinckrodt, Pezzer, or Ben-Ana. So this is a suprapubic catheter. So again, we're not going up the urethra, we're making an incision in the abdomen. So you can read through this case, but it is an open belly case, and you can read through the steps by steps. But we are going to be exposing that bladder so that we can put that suprapubic catheter inside. I want to point out, if you flip it over to page 864, you'll see that they're going to have to do a rectal check on these cases because that's where you can feel the prostate. So because a surgeon might be doing a rectal check, you want to make sure that they are doing this before or after the case. And if they do it during the case, you're making sure that they change gloves. It's very common for them to be so focused on their work that they're not worried about sterility. That's okay. That's our job to make sure that they don't contaminate our sterile field. So you can do that in a very polite way, or just offer them a new pair of gloves. I have a new pair of gloves for you, sir or ma'am, and they will respond well to that, instead of going, hey, you need to change your gloves. You don't want to tell them what to do. You just want to offer them what they need. Okay, after that procedure, I'm going to skip to page 866. So this procedure I'm not going to go through. I want you to know that they can implant radioactive seeds into the prostate gland. So these are all up to the surgeon and how they want to treat this prostate cancer. So it depends on how involved it is. It depends on how long it's gone on for. Depends on the placement. Can they treat it surgically? Do they not have that option? Are we going to have to do just radiation? So that's how they decide which of these to do on your options for prostate. But one option is putting in radioactive seeds into the prostate. Okay, after that, I get to testicular surgery, so I can skip back. So on testicular surgery, we're going to start with a hydrocele. So you can see your hydrocele sac on this picture and how they're going to fix it, but it stops at the anatomy, so I'll go there first. So hydrocelectomy. Know the different layers of the scrotum, and then know your tunica vaginalis. So your tunica vaginalis is a serous sac that's covered by most of the testes. It's also covered by the epididymis and part of the spermatic cord. I want you to know that term, tunica vaginalis. As you're reading through, I want you to focus on the seminiferous tubules. The seminiferous tubules. So these tubules are lined with that specialized tissue. It's germinal epithelium, but I want you to know it's specialized tissue that produces sperm cells. So that's where your sperm is produced inside the body. I'll stop at that. I'll let you read through the rest of that anatomy. Make sure you know your terms. If you flip it over to page 870, you'll see what a hydrocele is. So a hydrocele is that abnormal accumulation of serous fluid around the testes. So that's contained within that tunica vaginalis, that anatomy that hopefully you already knew. So I don't need to go through this procedure because you can actually see it in the picture that I provided. So you can see the different steps that we'll be taking. I will point out that because there's not great retractors for this type of tissue, many times you'll be holding a clamp out of the way or just using your hand as retraction. So they might ask you to just place your hand in a certain way so that you can retract that tissue out of the way. So keep in mind with GU, just like GYN, we're very hands-on. So you will be hands-on with these cases and helping out a lot. Be prepared for that. Okay, on page 871, I think we can move forward to orchipexy. So we'll talk about orchiectomy, but the anatomy is the same. So I do not have human anatomy over here. We have just a great picture of the vessel loop they're going to tie around it and what it looks like when they pull this out. So I wanted to provide a good picture. So I want to point out that's not human anatomy. Could steal that from our vet assistants, but the idea is still exactly the same. So you have an undescended testicle that they're going to have to pull down on an orchopexy. So looking at page 871, know your term cryptorchidism. So it can occur when one or both testicles fail to descend. So this is after the first year of life. The disorder is commonly associated with premature birth and is accompanied with inguinal hernias. So if you're doing an inguinal hernia, you can think about what else this patient might be dealing with too. Torsion. Let's stop at torsion. So torsion of the testicle is twisting of the spermatic cord that causes extreme pain for the patient. Now you'll see where it says orchiectomy. So orchiectomy is necessary if the testicle is necrotic. So if you have testicular torsion, it starts turning on itself and turning on itself. If you don't go get it fixed immediately, that tissue can necrose and die, and you will lose that testicle because of it. So testicular torsion is not something to wait on. You want to go to the ER immediately. So I want to point out for this one, I already gave you an idea of what they could do this case for, right? Undescended testicle, testicular torsion, and then testicular cancer, trauma, or necrosis. There's lots of different reasons to do both of these cases, orchiectomy or orchiopexy. Okay, you can flip it over to page 872, and I want to point something out for you. So you see all of these straight hemostops that are clamped onto that skin on page 872. You can use those sharp retractors that I showed you in class that are nice and disposable. You can use those to actually retract a little bit better on these cases. So again, we have new technology and new cool toys to help us do this better. But you can see what they're doing on the orchipexy. They're bringing it down into the correct position. And then on the orchiectomy, we are removing it entirely. Okay, that brings me to page 874. So simple orchiectomy. I want to look at your practical considerations. So know that if the patient wants it, they have implants for this. So if you had an orchiectomy, you'd like an implant put in so you have normal looking anatomy, we can do that. And they have, of course, different sizes so you can match up the sizes. After that, I want to point out the removal of one testicle is going to be an indicator for testicular cancer, trauma, or necrosis, like I was talking about, due to torsion, testicular torsion. Then look at radical orchiectomy. So this one is normally performed for cancer cases. And know what all they're going to remove on those. After that, look at a simple orchiectomy. No, we're just going to remove the testicle and the epididymis on this one. Okay, that's your orchiectomy and orchipexy. Now let's look at circumcision. So circumcision, you will not only be doing this on children. It's people of different ages, especially the elderly patients, maybe in nursing homes. They're not getting cleaned properly or they're not cleaning themselves properly. This can give you a big chance of infection if you still have your foreskin. So because of that, we will go in and do a circumcision on older patients also. Okay, your anatomy. I want you to read through and remember your anatomy, like your corpus spongiosum and all your different layers. So as you read through that, I want you to, right side of the page, top paragraph, it's talking about some more of the anatomy. So the skin forms a free fold called a prepus, or more commonly known as the foreskin. So I want you to know both names. As usual, we have two names for everything. After that, keep reading through your anatomy. I'm going to go to your equipment, instruments, and supplies. So for this one, know that you'll need a needle tip cautery for your bovie. This is because of the type of tissue we're bovieing on. If we use a big flat bovie, we're just charring big pieces of tissue. We want fine and very small so we can just burn what we want to burn and not cause any extra damage on this delicate skin. And then for your dressings, I want to point that one out. Adaptic. If you don't remember what Adaptic is, that's okay, but you should look up a picture of it and see that it is an occlusive dressing. It usually has petroleum jelly infused in it, so it's non-occlusive. So they can wrap this around these sutures and know that when they take the dressing off, it's not going to hurt that patient at all. It's non-occlusive. Okay, so you can see that procedure step by step, what they're going to do. This is another great example of when you're going to have to just retract with your hands. They might have you hold skin out of the way or actually hold the penis while they are sewing on it. So again, be prepared for what you're going to have to do in GU surgery, but you're just assisting like you're assisting on other surgeries. That's how I always thought of it. Just doing what needs to be done for our patient. Okay. I think I can move on now. So for male patients, Hypospadias repair. There I am, 879. So this one I actually have a great picture of all your different options. So you can see where the urethral opening is going to be and why we need to go in and repair it. So on this first one, your hypo, of course, the opening is lower than it should be. I don't need to read through that. You see how we're going to fix it. So now look at page 882, epispadias repair. This one's your congenital condition of the urethra, but you see we're going to fix that the same way. We want to fix the opening of the urethra and make sure it's in the correct position. That is what we're doing on all of these cases. So see the different openings and know a little bit of the anatomy as you see in this picture on your page. But really, I just want you to know the difference between all the different abnormalities that can happen with your urethral opening. And we, of course, want that urethral opening to be in the correct position so that our patient can urinate normally. Okay, that brings me to penile prosthesis. So page 884. Insertion of an inflatable penile prosthesis. So many different reasons for this case also. So impotence can occur for many different reasons. So diabetes mellitus, trauma, damage to the nerves, penile trauma, priapism, diseases, including vascular diseases, and there's even more that they haven't listed here. So many different reasons to get a penile prosthesis. I want you to look at your equipment, instruments, and supplies. You will have a sales rep usually that comes in with any type of prosthesis. So even for this one, you'll have a rep that comes in that's selling the item, of course, but they're there to teach you how to use it and set it up. So they will help you prepare this item for implantation. Your equipment, instruments, and supplies, I want to point out you'll need your Hagar dilators. Hagar dilators. After that, you'll see your position is easy, you're in supine, and let's look at practical considerations. So the most serious complication of this one is SSI. Anytime we're implanting something outside of the body, we have a big chance of infection, but look at the area we are implanting this in. Because of this area, this dirty area, you have more of a chance for infection. That's why it talks about establishing a specific area for the implant on your table. This allows no lint from your towels, none of that, things that can fly in the air and to get on your implant. You want to keep this separate from other things, put it on top of an item that's impervious, nothing like a towel that has lint on it or a sponge like a lap sponge. Okay, so because of this, because of their worry with SSIs, they will be irrigating this case with antibiotic solution. On page 885, you'll see that it's talking about labeling the different drugs that you'll receive on the table. So due to the number of drugs that will be on your sterile back table, the ST needs to be very vigilant about receiving one drug at a time and labeling it. So after you label it, you can receive the next drug and apply the label, so on and so forth. So make sure you're doing this one at a time and you're not mixing up, say, the saline versus the heparin. That could be very harmful to your patient. Okay, after that, the implants. So with most of these implants, you don't want to open it until it's absolutely needed. So this allows for less risk of contamination. There's no lint from the towels, anything like that landing on it too. But in addition to that, we're making sure that this is the right thing that we need. If I open this before the patient gets in the room and then we're in the surgery and they go, man, this isn't the right size, we actually need a different size, I'm gonna have to tell them, ooh, I already opened it. So now our patient's getting charged for 2. That's not ideal. Anytime you can wait on an implant, always communicate with your circulator. They could have it right there on the desk, and all you have to say is, I'm ready for my implant. They can pop up and open that to you from that point. And you have less a risk of contaminating it throughout the case. I also want to point out on this one, if you're looking at your picture, you see the different retractors. You can also see those hook retractors that I showed you in the classroom. So you will pass these with a hemostat attached so that they can loop it onto that tissue, pull back and attach that hemostat, and it retracts for you. I love retractors like this because that means I don't have to put my hands up on the field and retract. I can focus on passing instruments and getting through this case. Okay. I don't have anything else for penile prosthesis, so I'm going to move on to penectomy. So I'm on page 886. So know that a penectomy, this is done for cancer cases. So penile cancer that's not responding to radiation or chemotherapy. So this is a involved cancer that we're having trouble dealing with. This is not a common case at all. So very rarely seen. I doubt you will see it as a student, but you need to understand why we're going to be doing the procedure. So focus more on your anatomy and pathology on this one. Okay, that is it for genitourinary surgery, actually. So hopefully you are separating the different kinds of surgery because we've got a lot with GU. You can do open belly and flank incisions to get to the kidneys and do that ileoconduit. You can do genital surgeries where you're working on the penis in males. You can do specific bladder surgeries where you're doing cystoscopy and we're looking inside the bladder to do our resections. So many different options with GU. Make sure as you're reading through, you understand whether it's an open case or a cystoscopy type of case. So think about it as you're reading through the case. Do I have to count instruments on this case? Do I have to use a certain type of irrigation, certain type of fluid for the patient? Things like that I want you to think about as you're reading through these procedures, and I think it will better help you prepare for extern because you want to get to the point where you are anticipating the needs of your surgeon. So every specialty that you get through, hopefully you're learning something new and you're seeing some similarities between the other specialties. So then you can apply that to your skills in the lab. Okay, well, if you guys have any questions about genitourinary surgery, please send me a Facebook message or an email. I'm happy to answer any questions about the material or anything you're confused on. So just send me a message. I'm here to help. Thank you guys. I'll talk to you soon.